So we describe tumours broadly. We often describe them in two different types. Those are primary tumours and secondary tumours. What we mean by that is a primary tumour is a tumour that has formed in the organ that you're looking at. So tumours can form in any organs of the body. They can form commonly in the lungs or in the breast. They can form in the GI tract, so in the bowels. They can form on the skin, often as melanomas. Sometimes they can even form primarily in the brain itself. But in this context of metastases, the primary tumour is the one that's grown originally. So let's say in the lung. A secondary tumour, or a metastases, is a tumour that has spread from that primary tumour to a different part of the body. And that's something that we unfortunately see in the majority of tumours can spread to different organs of the body, and particularly the brain. So a metastases that forms in the brain may have originated in, for example, the lung or the breast or the bowel or the skin, as I've said. Those are probably the most common, although we do frequently see them form in other organs as well. How do they get to the brain? Well, the most common route is through the blood. So as that tumour is growing in its primary organ, a small fragment, a few cells may break off that, enter the bloodstream, circulate around the body, and find its way into the brain. And the brain is a very well supplied in terms of nutrients and blood supply, and so cells that lodge in the brain can form secondary tumours or metastases and start to grow in those locations. And so through the blood is the primary route that they get there. So a proportion of metastatic brain tumours are detected incidentally, which means they were found through either surveillance scanning, so someone was just having scans to see whether something appeared, or they may have had a scan for a completely different reason and it was found incidentally. Now, the majority of metastatic brain tumours do present with symptoms, but they can be quite wide ranging in terms of those symptoms. So headache is an obvious one, particularly a new headache, a very severe headache, unremitting, one which isn't helped by painkillers or leads to nausea or vomiting, would be classic of a brain tumour. Seizures are something that we sometimes see, so loss of consciousness or episodes of involuntary shaking, that would be a seizure. And sometimes we become aware that a patient has a brain tumour as a result of dysfunction of a part of the brain that tumour is lodged in. So depending where the tumour has grown, those symptoms can be quite variable. The person might have, for example, weakness in an arm or a leg or a portion of the face, which may be permanent, or it may just be there transiently. They could have problems with their vision or with their speech or their understanding of speech. In some cases, rare cases, you may have changes in personality, or you might have other what we call disorders of higher function, so things like alterations in your memory or your attention span and so forth. So they can be quite wide-ranging in terms of the symptoms that people present with. That's why you have to keep an open mind and be aware of this possibility, particularly in patients who you know already have a cancer somewhere else in the body. So the primary way that a metastatic brain tumour in the brain would be diagnosed is through neuroimaging. Most commonly a CT scan, which is a type of X-ray of the brain, or MRI, magnetic resonance imaging. These are the most common techniques, and they are also the most important. So they give you information about where the metastatic tumour is, the number of them, the size of them, and can guide you in terms of the suitability of treatment. It's also important in cases where they are detected to get information about the stage of tumour if there is one in another portion of the body. So if we know, for example, the patient has a primary tumour elsewhere, they may need to be restaged, which means reassessed in terms of that tumour. Has it come back, or is it still there? Has it grown? Has it spread anywhere else in the body? So this often involves further scans. These might be CT scans of the chest, abdomen, pelvis, for example, or they might be PET scans of the body to look for tumours elsewhere. Well, thankfully, we've got a range of options to treat metastatic brain tumours now, many of which can be highly effective. So depending on the number of tumours, where they are and the nature of it, will dictate really the options available for the patient. So that is something which requires a consultation with a specialist so they can really go through those options in detail. But broadly, the options are generally divided into radiotherapy-based treatments. So it may be the right thing in some cases to do an irradiation, which will aim to control or kill the tumours in the whole brain. So that could be irradiating the whole brain, that's whole brain radiotherapy, or a portion of the brain, which is focused or conformal radiotherapy. Now, if you want to be even more targeted about that and you want to avoid irradiating normal healthy brain and you want to be very specific and deliver high doses of radiation just to kill the tumor cells without affecting the rest of the brain, then generally a treatment like stereotactic radiosurgery, also known as gamma knife, is the best option for you. That will avoid damage and the side effects that come from irradiating normal brain. And it will also avoid some of the risks associated with a surgical approach, which is sometimes the right thing for patients, where you have an operation by a neurosurgeon like myself, where you have an active operation where an incision is made and the tumour is physically removed from the brain. Sometimes the right thing is to have a combination of treatments. So, for example, surgery to the dominant lesion, or even sometimes in the case of a solitary lesion, and then a subsequent treatment with gamma knife radiosurgery to the surrounding brain to kill any microscopic tumour cells which are left behind, which can't be seen during surgery. But the exact treatment that is correct for an individual patient is critical and requires discussion with that patient so that they really understand the options available to them and which is best for them. So in selected patients, gamma knife is a highly effective treatment for brain metastases. It has the fantastic benefit that it is non-invasive in terms of incision. So unlike traditional surgery, there's no cut on the scalp or the skull. It's all done non-invasively. And it has extremely high rates of control, so in excess of 80 or 90% for each individual tumour, so it can be very effective at controlling metastatic brain disease. Another fantastic benefit of it is that it's a day case procedure. So typically the patient would come in the morning and have a frame fitted, they would have a planning and then treatment, and by the afternoon they would be able to go home. And during that period they're able to eat and drink, there's no requirement for fasting, there's no requirement to stay in hospital, and patients tolerate the treatments extremely well. Like any treatment, of course, there are some risks of side effects, but the side effect profile is very good for gamma knife radiosurgery. So the chance of having a significant side effect is small, probably less than 1 in 100 cases.